Conversations Change Lives is a series about advanced care planning that may change the lives of the people you care for and their loved ones. I'm Dr. Susan Nelson, and having meaningful discussions with your patients about their future healthcare wishes are opportunities to better understand their preferences and to learn what's important to them. For patients with serious advanced illness, planning for future medical decisions is especially critical. In our state, the Louisiana Physician Orders for Scope of Treatment, or LaPOST, can be used to record these treatment plans. This video lesson for healthcare professionals is designed to review the LaPOST document, explain the 4 different sections, and discuss how to complete it. The LaPOST document, a 2-sided gold form, can be used to guide conversations with your patients and to encourage them to talk about treatment wishes and goals of care. The document then translates the treatments desired into physician orders that transfer with patients across care settings and is available to other healthcare professionals that are involved with their care. Let's take a closer look at the document. On the front side, you'll see a section at the top for patient identification and for documenting the life-limiting illness as well as goals of care. The first section, Section A, covers cardiopulmonary resuscitation, or CPR, with 2 choices: to attempt resuscitation or not to attempt resuscitation when the patient is unresponsive, pulseless, and not breathing. It's important to share facts about the realities and results of CPR with patients and family members. Many people are influenced by how CPR is administered on television and in the movies, along with a perceived high success rate. In actuality, studies show that the success rate for most of us in a hospital setting would be less than 20%. The success rate for frail, older patients or people with advanced illness is less than 2%. In short, CPR doesn't work very well in the elderly or very ill population. Equally important is discussing the results of CPR if it's partially successful. For example, what if the heart resumes beating but the brain doesn't function? What happens if the patient is too weak to breathe on his or her own and requires assistance? And what if the patient is unable to return to his or her current living situation? Where will the individual receive care? These are hard but necessary topics to explore with your patients and their caregivers. The next section, Section B, deals with medical interventions, beginning with full treatment. This is the broadest scope of treatment and includes CPR, ventilators, antibiotics, and medications to raise blood pressure, among other things. In short, it may involve treatment that would be performed in the intensive care unit, or ICU. Selective treatment is the second option. It always includes comfort-focused treatments and may, for example, involve hospitalization, surgery, antibiotics, IV fluids, and blood transfusions. It doesn't usually involve treatment in the ICU. The third option is comfort-focused treatment, maximizing quality of life, whatever that might mean to the patient and family. Comfort treatments are those focused on pain and symptom management with medication or other means. The patient receiving any of these 3 interventions will always be cleaned, turned, positioned, fed, and receive appropriate medication. Hospitalization may be involved, but only if comfort cannot be provided in the current setting. Additional orders enables you to individualize care plans for your patients depending on their particular situation. Explaining these interventions to your patients and what they aim to accomplish is very important because this document is all about them and realistic goals of care. The third section, Section C, deals with artificial hydration and nutrition and the most appropriate item checked after careful discussion with the healthcare team. Oral nutrition and fluids must always be offered to patients if medically feasible and tolerated, but artificial nutrition by tube is not provided to patients who refuse the treatment or for whom the treatment is not medically indicated. For example, for patients who are dying or those with life-limiting conditions, artificial nutrition and hydration may be excessively burdensome, may cause physical discomfort, and may provide little or no benefit with regard to prolonging life. If this is the case, treatment is not required. In these situations, clinical judgments must be made between patients or their personal healthcare representatives and the physician so that the appropriate boxes are marked. Other options under artificial nutrition by tube include trial periods and long-term support. A trial period may be necessary to determine the course of an illness or to allow patients the opportunity to clarify their goals of care. For other patients, long-term nutrition may be medically indicated and desired. It's necessary to explore these issues with patients and their families and to discuss goals of care along with the burdens and benefits. Specifically, it's the time to talk with them about the difference between the inability to eat, disinterest in eating, and the dying process. When patients have life-limiting, irreversible conditions or are nearing death, they may be unable to eat and drink, forget how to eat, or may not be interested in eating. Because of this, it's important to note that these patients are not eating because they're dying. They're not dying because they're not eating. Families want to be able to do something to show their love, so it's important to identify what they can do to help or how they can support their loved ones. This can be a very difficult and emotional conversation to have, and I encourage you to develop your own discussion for these talks with support and resources that can be found on the LaPOST website. Next is a place for the summary of goals, and it documents the basis for the orders: the patient, a personal healthcare representative, or the patient's advance directive. We use personal healthcare representative to represent all the people that are allowed under Louisiana law to make decisions on behalf of a patient. The last section is for the required signatures of the physician and the patient or the patient's personal healthcare representative. The physician must have a Louisiana medical license, but does not have to be on the medical staff of your institution or facility for the document to be honored. On the second page, there is another demographics line and a list of additional directions for healthcare professionals about completing the document. For example, any section that is not completed implies full treatment. Other key points deal with CPR, artificial hydration and nutrition by tube, comfort treatments, dehydration, revocation of the document, and religious and cultural considerations for end-of-life care. The last section encourages review of the document when patient transfers are involved or if there's a significant change in health status. Completion of a new document is recommended if patients want to make a significant change to their goals of care. If this occurs, the old document must be properly voided and retained in the medical record. To void the document, a line must be drawn through sections A through C, and void must be written in large letters along with the physician's signature and the date. In closing, completion of the LaPOST document helps healthcare professionals discuss, develop, and honor treatment plans that reflect patients' end-of-life care wishes. I hope this video lesson provides you with an overview of the LaPOST document and an explanation of the different sections. For more detailed information, please visit our website at la-post.org. Here you'll find a toolkit for healthcare professionals as well as additional resources to assist you. Thank you for watching.